We've had such an amazing day, and we are going to end on a high note. It's my pleasure to introduce our final speaker of the day, Dr. Kapil Kumar, who has prepared a wonderful talk for us. Dr. Kumar is an instructor in medicine at Harvard Medical School. He is board certified in both cardiovascular diseases and clinical cardioelectrophysiology. Dr. Kumar will be giving us a talk on improving the evaluation and management of syncope. Please welcome Dr. Kumar.
Thank you very much for the introduction. It's always a pleasure to be here every year. Thank you for inviting me back. And it sounds like you just had a long day, but just an excellent talk on atrial fibrillation. So hopefully I can keep following that up here. So I have no relevant disclosures for this topic. So we're going to discuss syncope, but also start with the history and exam, the importance of it, the importance of different types of testing and what the yield is. And then we'll discuss treatment in particular for vasovagal type syncope. And we'll touch a little bit upon orthostatic hypotension related to syncope. All right. So first, the definition of syncope. So syncope is defined as an event of global cerebral hypoperfusion, which leads to transient loss of consciousness and postural tone. So it's important you have both of them. It's typically very rapid and brief, usually on the order of seconds, generally less than a minute. There's spontaneous recovery, and there can be a variable prodrome symptoms for this. So why bother talking about syncope? The real reason is most people who have syncope generally do fine, but a small subset of patients who have syncope do very poorly. And that's people who have cardiac causes of syncope. So it's very important if we identify the cardiac cause of syncope, and then we can really impact this morbidity and mortality that occurs with syncope. And for a lot of the cardiac causes of syncope, there are available treatments. And if you have timely available treatment, you can make a huge impact and shift this curve that goes down up to the normal curve with everyone else even having vasovagal type syncope. So we'll start with the first case. So this is a 26-year-old female, no significant past medical history. She has her first episode of syncope in the setting of very heated argument with her parents. There's no prodrome. Her parents witnessed this. She has arm shaking vigorously for about 2 to 3 minutes. She's incontinent. She's confused upon waking and really disoriented for at least an hour. Upon evaluation in the emergency room, she has no orthostatic type symptoms. Her laboratories and ECG are normal, and her exam is mainly significant for horizontal nystagmus and some tongue bleeding. So what do you do for this patient? No further testing, discharge her home. Do you do an echocardiogram, a head CT, stress test? Do you give her fludrocortisone to keep her blood pressure up? I'll give a couple of seconds here. It looks like head CT and MRI are predominant, and that's correct. This is likely a first-time seizure. So the point of this case is we have to weed out the imposters. What's true syncope and what's not syncope? So things like hypoglycemia, hypoxia may cause you syncope, but there's not necessarily cerebral hypoperfusion involved. If you have sleep disorders like narcolepsy, it's not really cerebral hypoperfusion, so that's not counted as syncope. If you have a drop attack, you lose your postural tone, but you don't lose consciousness. Again, not syncope. If you have a coma, you pass out, but you don't have spontaneous activity recovery. And similarly with seizures, no cerebral hypoperfusion. So it's very important to know that we're really talking about syncope and not other illnesses. So case 2, again, a 26-year-old female, no significant past medical history. She presents with the first episode of syncope, again in the setting of a heated argument with her parents. She reports being lightheaded, no palpitations or chest pain or dyspnea, but her parents noted that she was, her arms were twitching a little bit, but she looked really pale. Her eyes went to the back of her head. She was nauseated upon getting up, but after about 15 or so minutes, she felt back to normal. On examination, things look normal. She's not orthostatic. She has normal exam, labs, and ECG. So again, same choices for her. What would you do for her? All right, good. We won't spend too much time in here. So yeah, so things like majority agree that really no further testing, you discharge her home. This is very likely vasovagal and neurocardiogenic syncope. And I really want you to take home for this point is that both of these cases very, very similar. same age, same setting, but little minor things in the history really told you what the diagnosis is. So this is just to point out that the history is extremely important for here. So this is just a slide on differences between like seizures and neurally modulated syncope. So typically in vasovagal type syncope, often you're warm and clammy. Some will say that they look pale. Seizures may occur while you're supine. Vasovagal syncope much less occur while you're supine. A little bit more common to have tongue biting and seizures. Incontinence is a little bit more common in seizures. The duration of syncope or passing out or unconsciousness is different. So for vasovagal type syncope, generally less than a minute. And for seizures, it can often be for many minutes. So again, the detailed history is really the first and most important tool in the diagnosis of syncope. The injury that someone sustains while having a syncopal event does not correlate with the actual etiology. The only thing that correlates is what the activity they were doing at the time this happened. So they could have a vasovagal syncope and it's benign, but if they're on top of a ladder or on a roof and they fall down and break their neck, that doesn't make the syncopal episode more dangerous. It's just the injury that they had was more dangerous because of the activity that they were doing. So when you talk about history, you really want to dive in very deeply to history. So circumstances, what were they doing? What time of day? Did it relate to eating at all? Was there any kind of emotional or painful physical stimulus around that time? Were they going to the bathroom at the time? What position does this happen? Were they sitting? Were they standing for an hour or two? Did they just get up from a sitting position? Were they doing any other activity like exercising or turning their head quickly, as in carotid hypersensitivity? Did they have any prodrome like aura, nausea, diaphoresis, or palpitations? And how fast did they recover? Was it a really quick, immediate recovery and they felt nothing's wrong, which points more to an arrhythmia, versus they had really prolonged symptoms of nausea and feeling unwell, even though their vital signs had totally returned to normal? That's much more consistent with vasovagal type syncope. So there's a number of scores that you can use. They're all kind of basically doing the same thing. The main thing that you're trying to point out is, do they have any major red flags to consider a cardiac cause of syncope? So if they have palpitations at the time this happened, that's more likely to be cardiac cause. If they have a history of heart disease or an abnormal ECG, more likely to be a cardiac cause. If they have syncope during exertion, that's another big red flag. Syncope while supine it's a little bit milder, but that's also should be something to warrant further investigation. So less likely to be vasovagal type syncope. So on the exam, often always do orthostatic vital signs. That should be a must for anyone. Oftentimes it's missed in the emergency room, but you should definitely do that because that'll help differentiate if there's a likelihood of orthostatic hypotension, which is the second most common cause of syncope, only behind vasovagal syncope. Do a full neurologic exam, or is there any signs of tongue biting to suggest a seizure? Do they have any murmurs? And I usually examine patients in two settings, one sitting up and the other one leaning forward to get the base of the heart towards the stethoscope, so you hear aortic stenosis a little bit better, versus left lateral recumbent, you may hear mitral stenosis a little bit better. Is there PMI, diffuse, which would indicate a cardiomyopathy? What was the injury pattern that they had? Were they able to brace their falls? And this mainly indicates that they had some prodrome. They sensed that they were about to fall, so they tried to brace themselves. And then if they have like peripheral edema, is it symmetric or asymmetric, suggesting DVT or congestive heart failure? For orthostatics, the definition is when you go from a supine to an erect position, do you have a fall in your systolic blood pressure of greater than 20 millimeters of mercury or a diastolic blood pressure greater than 10 millimeters of mercury, and or they have a systolic blood pressure that's less than 90 millimeters of mercury, and their symptoms are reproduced. If they have symptoms with all of this, that's diagnostic. If they don't have symptoms and just have the blood pressure changes, that's suggestive of orthostatic syncope, orthostatic hypotension causing syncope. And the other thing to note is that this may take a few minutes to happen. The blood pressure drop may not be immediate from sitting to standing. So one very common scenario you'll hear is someone was taking a nap on the couch, they got up to go to the kitchen and they passed out in the kitchen. And all you get from the history is that they passed out in the kitchen, but if you ask them what they did before, they were laying on the couch for an hour or so taking a nap. And so they didn't actually pass out until 2 minutes later till they got to the kitchen. And that's still most commonly orthostatic hypotension. So here's a study about the diagnostic yield. So this is 650 patients that came to the emergency room, consecutive patients who presented with syncope as a primary complaint. And so everyone had a very basic workup. They all had a good H&P, they had an ECG, basic labs, and this one, they also did carotid massage. Then, if it was not clear what the cause of syncope was, then they had targeted treatment so that they did an echocardiogram, a CT angiogram, stress testing, various other tests. And if they still could not find out the etiology of syncope, then they did more aggressive testing, such as an event monitor, tilt table, or even an EP study. So they did a stepwise approach. So what they found out was for just the basic testing, so history, basic labs, and ECG, they were able to diagnose the etiology of syncope about 70% of the time. The most common was neurocardiogenic or vasovagal. Second most common was orthostatic. So that's about 50% of the time. And then in a small smattering of cases, it'll be an arrhythmia or other particular diseases like aortic stenosis or other valvular diseases. Sorry, just the lights went up. Targeted testing, so an echocardiogram, CT angiogram, and such, only increased the diagnostic yield by another 4%. And if they did even more aggressive testing, it only increased the diagnostic yield by another 4.5%. So even with all that testing, it did not help that much beyond what the basic testing, basic H&P did. And then even after everything, about a fifth of patients, so almost 22%, were still left without a clear diagnosis. And that's important to know. You may not always figure out why someone passed out. So history and exam provide the most value. Additional testing is low yield, high cost, so use it wisely. So when do you do other ancillary testing? So selective testing really is based on the key elements in the history and the exam and the ECG. If you find any abnormalities there, then you go down various testing pathways. So here's another case. So another 26-year-old female, again, no significant past medical history. She presents her first episode of syncope, but this time in the setting of a daily run. She gets lightheaded and had palpitations briefly before this happened. There were some witnesses around. They saw a little bit of arm twitching, but they noticed that her lips were blue. Upon waking, she actually felt well, maybe confused for a minute, but she was ready to run again. She didn't quite know what all the fuss was about. But they convinced her to go to the emergency room. And in the emergency room, she's not orthostatic. She has normal exam, normal labs, but her ECG is abnormal. So this is her ECG. So just for the interest of time, we'll go over it. So she is in sinus rhythm. She has pretty high voltages in the QRS complex are pretty high voltages, and her QRS, her T waves are very abnormal throughout their anterior precordium and laterally as well. So high voltage QRS and very abnormal T waves is suggesting that she may have something wrong with her heart. So what do you do for her? Do you no further testing, echocardiogram, and head CT because she did have syncope, stress test, or fludrocortisone to help keep her blood pressure up? All right. So I think most people would agree the echocardiogram. Some people did say stress test. It wouldn't necessarily be wrong to do a stress test. In practicality, you'd probably do an echocardiogram and a stress test. But if this was a board type question, the best next step would really be the echocardiogram because that's what's going to cinch your diagnosis. And this lady likely has hypertrophic cardiomyopathy. That's what the ECG changes are consistent with. And so if you did an echocardiogram, you would be able to diagnose it. If you did a stress test, you may or may not see any arrhythmia because this is not the first time she ran, but it's the first time she had the arrhythmia. So you may not be able to pick it up on a stress test. All right. So again, another case. Now you have a 46-year-old male. He had syncope while rushing up the stairs. He has a history of hypertension and is on lisinopril. He remembers feeling briefly lightheaded, but he denied having any palpitations before or afterwards, no chest pain, no dyspnea. There were no witnesses around. He was confused for maybe about 5 minutes. He was not incontinent. When he came to the emergency room, his blood pressure was 110/70, heart rate in the 80s, creatinine 0.9 at its baseline. BUN is a little bit elevated. He was mildly orthostatic, but didn't quite meet the definition of orthostatic hypotension, and his exam was otherwise normal, including his ECG. So again, the same thing. What do you do for this patient? Interesting. This is more of a spread. So let's see. All right. So many people are saying hydrate and discharge home, which may be okay, but remember, exertional syncope is a red flag. You should not discount syncope during exertion. So this warrants further workup. So he may be dehydrated. He's a little bit off the side. That may be true, but this happened while he was exercising. You can say you can do an echocardiogram as well or a stress test. Again, this happened while he was exercising, so maybe a stress test is better. His ECG is normal. His cardiac exam is normal. So echocardiogram is maybe a little bit less likely to yield the diagnosis. So we did a stress test in this patient, and this is his stress test. So he has ventricular tachycardia. So he already had it at many other times. And this is likely idiopathic outflow tract ventricular tachycardia, which people typically don't pass out from. But he ended up having the perfect storm where he was likely a little dehydrated to begin with. And then he had a VT on top of that with exercise. And that's why he passed out. So we happened to catch it there. So the point of this is syncope with exertion is a red flag. So that warrants further evaluation. So just to talk a little bit more about cardiac testing. So an echocardiogram, I would have a very, very low bar of doing an echocardiogram for most people who present with syncope. It's it's an easy test to do, and it really eliminates a lot of different types of cardiac causes of syncope, like cardiomyopathy and valvular disease, right? Stress testing is probably a little bit less effective, so I wouldn't stress test everyone with such a low bar, but if they have syncope during or shortly after exertion, then you definitely should do a stress test. Okay. So moving on. So now we have an 83-year-old male. He has a history of chronic kidney disease. He has also a history of renal cell carcinoma, but in the remote past, more than 10 years ago. And this time he had syncope during his daily walk. He had a road trip about 2 weeks ago. He was in the car for maybe 5 or 6 hours. No prodrome, no witnesses. When he woke up, he was a bit dyspneic, maybe a little nauseated, some chest discomfort that's vague. In the emergency room, he is definitely orthostatic by blood pressure. So blood pressure drops. His heart rate's a little bit high. JVP seems elevated. He has a sort of a soft systolic murmur. He has asymmetric edema, and he also has bilateral carotid bruits, and his creatinine is up. And it's not clear if this is his baseline or not. So this is his ECG. This is his baseline ECG I have here, and this is his current one. And there are definitely some changes, right? So first, he's definitely faster. There was a rightward axis shift on his frontal QRS plane compared to his baseline. He has his deep S wave in lead 1. He has inverted T waves in lead 3 and a small Q wave in lead 3 as well. And then he has inverted T waves in the anterior precordial leads as well. So there are clearly many changes that have happened here. So what do you do for him? So he's orthostatic. Do you give him IV fluids, hydrate him? Do you admit him to the hospital and observe? Do you do other labs like a troponin, a BNP, D-dimer? Do you consult cardiology for an urgent cardiac cath since he has these major EKG changes? Do you obtain a head CT and carotid ultrasound given the fact that he had this finding and he had syncope? I think everyone is pretty much in agreement that we need to look further before just saying, just admit him. So look at his troponin, BNP, and D-dimer. Let's see what we have. So his troponin is mildly elevated. This is the old, not a high sensitivity troponin. This is the older troponin. So 0.18, so it's a little bit above what we call acute MI. His D-dimer is certainly elevated, and his BNP is also a bit elevated as well. So again, is it orthostatic hypotension, echocardiogram, CT angio, cardiac cath, or head CT? Interesting. So many are going for CT angio. Some are considering cardiac cath, probably because of the troponin elevation, the ECG changes. But I think CT angiogram is likely the way to go because he had the remote history of cancer, but he had the long trip and the D-dimer being elevated. So I would do a CT angiogram, and this is his CT angiogram. So he has large bilateral pulmonary emboli. So he probably had a saddle pulmonary embolism that broke off bilaterally, and that's probably why he had syncope. And so looking at other laboratory testing. So you can do troponin and BNP testing, and whenever they're elevated, it doesn't necessarily mean it's heart failure or if it's coronary disease. What it tells you is that there's some cardiac stress. There's some cardiac issue going on, so we need to look further for cardiac etiology of this syncope. And that's how you should really use it as a screening test that way. Okay, so here's a study on, what is the real role of D-dimer testing? So this is a study that was done out of Italy several years ago. So about 2,500 patients were screened who presented with the first episode of syncope. Only a small portion were enrolled because a lot of them were eliminated because they either were on anticoagulation or they had a clear other cause of syncope. And what they all had was a very detailed workup in terms of history, physical exam. They all had a D-dimer as well. And so about 10% of the patients had a positive D-dimer. Only about maybe 5% actually had elevated high pretest probability. And as a result, all of these guys underwent a CT angiogram or a VQ scan. And of these, about 97 were confirmed to have pulmonary emboli. So in the major bottom line of the trial, that was about 17% of patients presenting with syncope had a pulmonary embolism. But if you really look at all comers, it's probably closer to something around 3 or 4%. So pulmonary embolism may be an important etiology of syncope. Etiology of syncope for patients who are admitted or present. And only about probably 4% of the actual all comers probably have a pulmonary embolism, because there may be a lot of people you may diagnose with a pulmonary embolism, but it may not be the actual etiology of syncope, because in many of these cases, some of these pulmonary emboli would actually branch vessels much further down, and it's hard to imagine why that small pulmonary embolism would really cause syncope. Here's another meta-analysis of syncope and pulmonary embolism. So this took patients who were hospitalized or in the emergency room with syncope. So it was about 7,500 patients. But the difference between this study and the last study is that there was no systematic evaluation for pulmonary embolism. This is more of a retrospective study. And here the pooled estimate was about 0.8% to 1% of patients who presented with syncope had pulmonary embolism. So the truth is somewhere in that single-digit range, most likely. So I just wanted to touch base a little bit about how syncope can result from pulmonary embolism. So any structure or physiologic abnormality that limits augmentation of cardiac output, especially during exertion, so this patient was walking, may lead to global cerebral hypoperfusion. And that's the key here. So anything that decreases increasing cardiac output. And so in terms of valvular disease, the most common things that will cause this are aortic stenosis and mitral stenosis. Regurgitant valve lesions will rarely cause syncope because they don't necessarily prevent increasing cardiac output. They just make the cardiac output less efficient or heartbeat less efficient, but they don't necessarily limit the augmentation of cardiac output, whereas a fixed stenosis will do that. And what's happening in pulmonary embolism is that the right ventricle cannot push beyond the increased resistance of the pulmonary arteries that are now occluded because of the embolism. Okay, here's the next case. So 69-year-old female with a history of asymptomatic paroxysmal atrial fibrillation, hypertension. She's on warfarin. This is the second time she's been unresponsive while watching TV in 2 months. She reports remembering her vision kind of blackening before this happened. Her husband was there, noticed that her eyes rolled back. She did not have any kind of jerking movements. This lasted for less than a minute. Upon waking, she generally felt well. No nausea or vomiting. And on workup, she's not orthostatic. She's normal exam and laboratories. Her ECG is mainly significant for some sinus bradycardia, but is otherwise pretty normal. All right. So what is the appropriate cardiac monitor for this patient? So we know we all are suspicious that maybe something cardiac is going on, but how best do you monitor her? All right, looks like there's not, there's some other dissenters here. So some are saying implantable loop monitor. All right. Okay, so it's a good point that I bring this up now. So there's several people who say Zeo patch, 2 weeks, no live monitoring. Several will say mobile cardiac telemetry. Some even say implantable loop monitor. So the correct answer here is really mobile cardiac telemetry. So a Zeo patch that has no live monitoring is not appropriate. So any kind of monitor that does not have live monitoring is not appropriate for her, because what if she had a major conversion pause? If you just did a Zeo patch that does not have live monitoring, you're not going to get that report back until 2 or 3 weeks later, right? So you want to know now why they had syncope if they have it again while wearing this patch. So that's why this would not be appropriate. You really need live monitoring or mobile cardiac telemetry. An implantable loop monitor may be an option, but typically before going that route, you may come up with a diagnosis with mobile cardiac telemetry, and this is far cheaper than an implantable loop monitor. And most insurers will require you to do this before you get an implantable loop monitor. Okay, so just different methods of syncope. So the big thing for last one is you cannot use a non-live monitor. So that's not appropriate for people with syncope. So an ECG is a great screening tool, but it's only 12 seconds. But it's cheap, low yield, but very cheap. Then the Holter monitor is 24, 48 hours. So this is useful if you have very frequent events, right? The likelihood that she's going to pass out again in the next 48 hours is very low. Then you have the extended monitors for less frequent events. So something happens once or twice a month, you may be able to pick it up. And the loop monitors are really for things that are recurrent but very infrequent. So something that lasts for maybe once or twice a year that it happens. So a loop monitor will be good for that. And invasive EP studies, it's most helpful if the patient has some structural heart disease already, or a clearly abnormal ECG. And even in this category, it's much more effective for trying to figure out if they have tachyarrhythmias rather than bradyarrhythmias. So if someone had a conversion pause or heart block, it's sometimes difficult to reproduce that or differentiate that on an EP study, where if someone had ventricular tachycardia, you'll have an easier time trying to reproduce that during an EP study. Here are different types of monitors. Here's a typical Zeo patch, and now Zeo patch does have live monitoring as well. There's various competitors to Zeo patch as well. Here's an older style Holter monitor, which I don't think many people use this anymore. Here's a Cardia monitor, which is an attachment for the cell phone. You can get a single ECG, but this is really not useful for syncope because they're going to take an ECG after they get up, not before they passed out. Similarly, an Apple Watch is not appropriate because they're not getting a real-time ECG. They're getting an ECG after they interact with the device. And this is what an ILR monitor is. This is the old ILR. This is the newest ILR monitor that we've been using for the last at least more than 5 years. There's several competitors to this now as well, and they're all similar size, very easy to do. And we'll touch base on this a little bit more. So when you look at, when you talk about arrhythmias as a cause of syncope, you break them up into two categories. There's the bradyarrhythmias and then tachyarrhythmias. So in terms of bradyarrhythmias, you break them up into two categories. So you can either have a problem with impulse generation, so you have sinus node dysfunction or conversion pauses, sinus exit block, sinus arrest, or you have a problem with impulse conduction, and that's AV block. So problem with the His-Purkinje system, you have high-grade block or complete heart block, and here's an example of that. And for tachyarrhythmias, similarly, you split them up into two categories. There's the supraventricular tachyarrhythmias, or SVTs, and then the ventricular tachyarrhythmias, or VTs. Most SVTs will not cause syncope. Of the SVTs that will potentially cause syncope is AVNRT, the most common, because in AVNRT or AV nodal reentrant tachycardia, the atria and the ventricles are typically contracting at the same time. And when that happens, that actually activates the the barosensors, and that causes a vasovagal type reaction. And that's most commonly why they have syncope with AVNRT, not because the heart rate is so fast. And the same thing with rapid AFib. Rapid AFib rarely causes syncope. People with AFib who have syncope, it's typically because they have a conversion pause, not because their AFib is so fast. Ventricular tachycardia, oftentimes associated with structural heart disease or inherited arrhythmias or metabolic issues. Sometimes pre-excited AFib, as in WPW, may look like ventricular tachycardia. Idiopathic VT, that one that I showed you before, is uncommon to cause syncope except in the right setting. So if you have the aligning of the stars, you're dehydrated, you're pushing yourself, and then you have VT on top of that, you may potentially pass out. And the same thing with other SVTs that itself. Like that alone is rarely going to do it unless there's something else going on at the same time. So implantable loop recorder. So you should consider an ILR if the patient has recurrent syncope and the episodes of syncope are relatively rare. So you've done monitoring before and nothing has really showed up. It's a very simple surgical procedure. It takes about maybe 20 or 30 minutes to do. Some people can do it on the surgical in the office setting as well. These loop monitors actually can stay in the body for up to 3 years. They have a very long battery life and they have remote monitoring capability as well. So the patient does not have to come to the office to get a recording. It can be done remotely from home. And the big thing about this is that it eliminates any kind of patient noncompliance. And ILR for syncope has really become the gold standard for people who have recurrent unexplained syncope. So here's two trials that looked at people with recurrent syncope. Those were randomized to either having an ILR or conventional management, even with a syncope clinic that they go to. And patients who had an ILR monitor were much more likely to get a real diagnosis earlier, right? In both studies, about 50% of the time within 1 year, or this study within about 3 months, versus have conventional management. So ILR is the most effective in establishing or refuting an arrhythmic etiology for recurrent syncope. In some ways, there's an argument to make maybe it's cheaper, but ILRs themselves are relatively expensive. Each ILR is about $4,000 to $5,000, so that's about the price of a pacemaker. That's pretty expensive, but if it saves repeated ER visits and repeated workup, then it may be potentially cheaper. All right, so next case. So 81-year-old female now with a history of CAD and atrial fibrillation along with diabetes and CKD comes in with an unwitness fall resulting in a wrist fracture. She has no recollection. She cannot remember if she actually lost consciousness or not. There was no witnesses. When she was found, she was having some nausea as well as wrist pain. In the emergency room, she has mildly orthostatic blood pressure. There's no clear head trauma. She does have a left carotid bruit, and she has right hand pain and weakness, which is potentially a wrist fracture, and no other deficits. So what do we do for her? Which is the least likely to be useful? Echocardiogram, head CT, carotid ultrasound, D-dimer, or an event monitor. So least likely. All right, there's some few dissenting opinions here. Not everyone wants a head CT or carotid ultrasound. All right, so the least likely in this situation is going to be the head CT and carotid ultrasound. So what is the value of neuroimaging in syncope? So here's a study that took 1,100 patients who presented to the ED with syncope without any and only mild head trauma. So no head trauma, only mild head trauma. They had normal neurologic exams. And what they did was follow these patients for the various testing that they had, if they had any neurologic testing. And in this cohort, 62% had a head CT performed, and about 10% actually had a brain MRI. And of these 800 studies, none, so 0 of the 800 studies had any clinically useful findings related to the syncope cause, right? So the key takeaway here is if you have no focal neurodeficits and you did not have head trauma, brain imaging is not necessary. So the only reason to really order brain imaging is if you have seizures or a CVA or other head trauma, so that you're suspecting some neurologic event. Even if you had a carotid bruit or so, and you may have carotid stenosis, unilateral carotid stenosis is not going to cause syncope. To get syncope, you have to have either affecting the reticular activating formation or global bilateral cerebral ischemia, right? Which one-sided is not going to get you. So here's another test to try to figure out what the true cost of neuroimaging is in syncope. So here's a study, I believe this was out of Yale, 2,100 patients greater than 65 years of age who presented to the ER with syncope. And they looked at the various testing that they had and tried to correlate what the cost of the testing was to actual yielding a diagnosis. So cheapest, orthostatic. So the $17 is really the amount that you would pay for the nurse to do the orthostatics. If you had telemetry, you found arrhythmias, and EKG was a great screening tool. So most of these cardiac issues were good screening tools. As you get higher up, it gets a little bit more costly for diagnosis, but still within reason. Then you start going to neuroimaging. So here, EEG is a very cheap test, but very, very expensive because it rarely used a diagnosis. In this particular cohort, head MRI was very quote unquote, cost effective, mainly because people were screened highly before they had an MRI. Head CT, people were not screened, and it's very ineffective because of cost for developing a diagnosis for syncope. So really refrain from doing neuroimaging unless you have some strong suspicion some neurologic event is happening or there's head trauma. So this is basically the same. So unless you have any associated findings, sometimes if you have a TIA of the vertebral basal symptom, you may have some drop attack, but may not necessarily have the same type of syncope, or you may not have total loss of consciousness, but that can sometimes mimic a syncopal episode if you have a TIA of the vertebral basal symptom, because you may affect the reticular activating system. So here's another case. So 46-year-old male now with recurrent syncope. He is 5 times over the last 2 years and associated with a stressful emotional event. He gets lightheaded. He's cold sweats. It's always the same thing every time. People have often said he looks white as a ghost when this happens. He wakes up, he has nausea and vomiting, and takes him about 30 minutes to feel better. He comes to the emergency room many times. His blood pressure is within reason at his baseline. Heart rate's okay. It's not orthostatic. Exam is okay. Labs and ECG are all okay. So, which therapy can prevent recurrent syncope in this patient? All right, so it looks like most people are looking for physical counter pressure maneuvers and salt volume loading. We have a few other takers now. All right, so I'll just go on just for the interest of time. So in actuality, you're all correct. All of these things can help prevent recurrent syncope, all to various degrees. And the easiest and cheapest thing is obviously the physical counter pressure and the salt volume loading. So that's why we typically use that first. And that probably has the least real data, but the most consensus opinion about it. And all the other options here have some data suggesting that they may help. So we'll go over some of that. So counter pressure maneuvers, salt intake, fluid intake, that's really the baseline. There's not a ton of data, so that's why it's a class 2A and 2B recommendation. And all the other stuff has some positive data for it as well. There's no one thing that's far better than the others. But in certain situations, you may have one may be better than another, and I'll tell you in another slide. So the key thing for this one is this is clearly recurrent vasovagal syncope, and he doesn't have any clear trigger that he can prevent. But if there was a trigger, you try to avoid that as much as possible. You recognize the prodrome, so you can lay down when it happens. So you don't actually pass out, but you may just get near syncopal. So it's okay to not eliminate all syncope or turn near, I'm sorry, it's okay to turn syncope into near syncope, so they're not actually passing out and they're not injuring themselves. And then it's also important to see if this patient has predominant vasodepressor syncope or cardioinhibitory syncope. So vasodepressor means that predominantly vasodilation as the cause of syncope, and cardioinhibitory, not only are you getting vasodilation, but you're also getting a significant slowing in the heart rate as well that contributes to syncope. So here, if you have someone who lives with a relatively low blood pressure, so starting off with something like fludrocortisone, midodrine, salt loading with salt tablets can help. If you have clear prodromes, perhaps these counter pressure maneuvers. If you are on hypotensive drugs, of course, stop the medications. But if you have a dominant cardio inhibition, meaning that your heart rate really gets really slow or you have pauses and asystole, then cardiac pacing may be of help. And then the next thing I'll talk about is cardio neuroablation as well, which we'll talk on in a second. So here is a question about tilt table testing. So a lot of people may do this for vasovagal syncope. I personally don't find it very useful. I think the sensitivity and specificity is too mediocre to really sway me one way or another as to what the diagnosis is. So at most, it can suggest if someone is susceptible to vasovagal type syncope or orthostatic hypotension. So I don't really find it very useful. Sometimes for patients with POTS or so, postural orthostatic tachycardia syndrome, it may be helpful because then you can really clearly demarcate that there's a minimal change in blood pressure, but there's an exaggerated response in heart rate. So limited value in establishing the diagnosis, limited sensitivity and specificity. Right. So here's a recording of an ILR in a patient who had recurrent syncope, and this is one of his Syncope episodes. So here's the QRS complex is going along, his rhythm is normal, starts slowing down a little bit, slowing down more, then he has really asystole, essentially, large pauses, and then he starts speeding up again a little bit here. All right. So that's typically what you would look for. And for people who have clear, strong cardioinhibitory syncope, in particular, if they have pauses greater than 3 seconds, then a pacemaker may be helpful. So there was a number of studies with pacemaker and syncopal people with vasovagal syncope, and they're of modest benefit, except in a select group of patients that you diagnose that they have asystole for greater than 3 seconds. And you can do this with a tilt table test or with an ILR. And you decrease the recurrent syncope by about 60% or so. So limited utility for selected patients. So this is an algorithm of how pacers respond to vasovagal type syncope. So typically they're just monitoring the heart rate. And if there's a precipitous drop in heart rate below a certain threshold or below a degree of drop, then the pacemaker kicks in and increases the heart rate to usually about, in this algorithm, about 110 beats a minute. There's another competing algorithm that's called closed loop system, where it's measuring the impedance in the heart, and that impedance correlates with sympathetic tone. When the sympathetic tone changes, it's likely a vasovagal event happening, and then the pacemaker can kick in to increase the heart rate and try to overcome some of that vasodilation. So cardio-neuroablation is a newer technique that's been used. It's very exciting because it can have a dramatic impact on vasovagal syncope for young people in particular. So what it's targeting is the intrinsic cardiac parasympathetic ganglia. So we know the sympathetic ganglia are in the sympathetic chain that's around or are parallel to the spine or the spinal cord, whereas the parasympathetic ganglia are actually at the target organs, and in the heart, predominantly they are around the epicardial regions of the atria. That's where they predominantly congregate. And so what this is basically a modification of an AFib ablation. So you're ablating from endocardially and you're ablating transmurally to affect these epicardial ganglia. And because the atria are only about 2 to maybe 4 millimeters thick, you are able to achieve transmural lesions. And by doing that, you can ablate some of these ganglia. You rarely can wipe out anything, but you can change the parasympathetic to sympathetic mix so that patients don't have as much vasovagal type syncope. And in this study, there's a number of studies that now have come out with, they're mainly prospective and retrospective studies that we've done, and there's 92% freedom from recurrent syncope, which is dramatic, far better than what pacemakers do. So this is a very common. I've used a number of patients, and they've had very dramatic effects. So instead of putting a pacemaker in some 30 or 40-year-old patient who's really debilitated because of the recurrent syncope, now by doing this ablation, you can really prevent that from happening. All right, so here's another case. So this is a 78-year-old male with Parkinson's, and he presents with recurrent syncope, most commonly with standing up quickly, or even if he stands up slowly, it still sometimes happens. He has no particular prodrome. He's already on midodrine and fludrocortisone. He feels back to normal after about 5 minutes. This has been happening for a while, and he's orthostatic with a 40 millimeter drop in blood pressure when you see him. Otherwise, he has a normal exam, normal labs, normal ECG. So, which is the least likely to help this? All right, so there's somewhat of a mix. Some are saying the abdominal binder and such, but there's a kind of a mix. So, least likely is most likely a dual chamber pacemaker. This is probably significant orthostatic hypotension without necessarily a significant cardioinhibitory or bradycardia component to it. Yes, his heart rate's often in the 50s, but even if you go from 50 to 60 or 70, you may impact the blood pressure only mildly. So all the other ones may potentially impact orthostatic hypotension. So now there's a number of drugs that has been studied. Most of these trials are very small, like 20 patients, 50 patients, generally less than 100 patients for a lot of these trials, except for maybe fludrocortisone that had a larger study. So these may impact orthostatic hypotension, but most commonly, what I find for most patients, you have to use a combination of drugs. So this guy was already on midodrine and fludrocortisone. Perhaps the next thing I would consider adding is atomoxetine. That may help as a norepinephrine reuptake inhibitor. There's some data on droxidopa, in particular with Parkinson's and other neurologic disorders, that may help with orthostatic hypotension as well. But really, you just have to throw everything at them and hopefully something will work. But these patients are very difficult to treat. So just in conclusion, so basic workup, a detailed history and examination along with orthostatic vitals and ECG will provide the greatest diagnostic yield. Remember the key red flags and signs and symptoms for a cardiac etiology like syncope while exerting yourself. Targeted workup for certain patients with echocardiogram, chest CT as warranted, as the history dictates. It provides a small additional yield. Recurrent syncope will dictate the type of monitor you will use. So the frequency, if it happens every couple of months, maybe you can get away with a regular monitor. If it's happening a few years, then you may need to have an implantable loop monitor, which has the highest diagnostic yield. And then neuroimaging, really only if there's some other focal neural deficits or head trauma involved. All right, thank you. Be willing to take any questions.
So thank you for a very strong finish to our day, Dr. Kumar. We do have a few questions for you. So in individuals who have underlying cardiac risk factors, what is the level of obligation in terms of doing additional targeting testing, even if you have a good history that sort of suggests that the cause is orthostatic or vasovagal syncope?
So I think if they should at least have an echocardiogram sometime in the recent past, like within the last year or so. If it's normal, not normal, I would at least do that. Assuming they've had that and your history is very suggestive of it, then it's okay to stop there. Right? It's okay to stop there if they don't have any of the other major red flags, as long as that workup has been done and they're following a cardiologist, depending on whatever other cardiac issues they have. But as long as they've had that before, that's fine. But if they haven't had that, then you're obligated to at least do a little bit more, at minimum, with an echocardiogram or maybe a stress test, depending on what the issue is. Yeah.
Okay. So given your advice about the role of orthostatic vital signs, do you have any guidance in terms of like the accurate way to do it? Do you always take people from supine to sitting, standing, and how many minutes in between blood pressures? Can you give any guidance?
The way I like to do it is go from supine to standing because you get the greatest difference that way. So I'll have them lay down for maybe a few minutes while I'm talking to them, getting their blood pressure and such, and then I'll have them stand up. And you need to wait at least a minute to 2 minutes. And maybe I'll do it in a minute. If it doesn't drop, I'll wait a few more minutes and then check the blood pressure again to see if it drops, because it may not be immediate and there may be some delay. Usually within 5 minutes, the blood pressure is going to drop if it's going to. Typically, it does not take like 10 minutes or 15 minutes to do that.
What recommendation would you give for older patients who have underlying hypertension but still recurrent syncope? And those patients, do you withdraw their treatment for hypertension?
So that's a challenging thing to do, because you don't want them to be too hypertensive. You want to have some permissive hypertension, but not be too hypertensive. So if they're running in the 190s, that's not great for them. But I will let them run in the 140s, 150s, and not put them down too much, because it's better that you have a little bit more hypertension versus having syncope. That's where they're going to really hurt themselves and cause major morbidity, right? So I will let them run higher. So sometimes it's very difficult because the patient, I imagine, it's 40-point drop. So he's going from like 140 to 100. That's a big difference. But I will allow the blood pressure to be close to the 150s, even 160, depending on how often the syncope is happening and how bad their orthostatic hypotension is. Yeah, and then there's some, I'm sorry, just to add that, there's some suggestion that depending on if your blood pressure is labile, but if it's certain times a day that it's high and certain times a day that it's low, perhaps you can change the timing of your antihypertensive medications, like instead of taking in the morning, maybe taking in the evening or midday or so, and that may help to ameliorate some of these labile changes.
Thank you. What's the role for carotid ultrasound and syncope workup?
So as I mentioned, very little. So it's not very helpful. Even if they have a carotid rule, you can do the ultrasound, but you're not doing it for syncope, right? So especially if it's a unilateral thing, even if that carotid is totally blocked or acutely blocked, because of the circle of Willis, you have a lot of redundant blood flow. So it's unlikely that's going to cause global cerebral hypoperfusion. Right. So unless you have that, you're not going to have syncope, at least not unless you have again, the reticular activating formation and a vertebral basilar TIA maybe. But typically, there's very little role for carotid ultrasound in this. Yeah.
Great. I'm wondering if you can say a little bit more about POTS. Some individuals are mentioning that there's skepticism. It's sometimes a controversial diagnosis.
Well, POTS is a real diagnosis. So there's skepticism in terms of it's related to maybe COVID and other viral things that can happen. But there are definitely people who suffer from POTS where they're typically really debilitated most commonly, and it's most common it's young women who have this, but they have these really exaggerated swings in heart rate with minimal changes in blood pressure or change in position, and so it's a real entity. And so treating them initially with like beta blockers just to lower their heart rate and stuff, many times some of these patients will also generally run a little bit low on the blood pressure. So one of the things we found is ivabradine is one of the new Corlanders used for heart failure, but ivabradine is the generic name for it. That can help ameliorate some of these symptoms from POT. But I think it's definitely a real entity. I see a number of patients with it who are really debilitated. And that's where I think the tilt table comes in most handy because you can truly document that very nicely there.
Is there anything classic about the presentation of syncope that might make you sort of think POTS is higher on the differential?
Usually it's recurrent. It happens. They're plagued by it all the time. It's not like one off, once a year they'll have it. This is like they're having almost every day, once, twice a week. They're really debilitated. That's what true POTS is. It's really debilitating. Then there may be some very milder versions of it that you can question, is it truly POTS or is it just, a little hypotensive or so? But the true what I categorize as POTS, they are usually very debilitated and there's very frequent symptoms.
Got it. And then the last couple of questions pertain to just older adults. And those who maybe have cognitive impairment and can't give a reliable history, if syncope is on your differential, is that an indication where you might do a head CT? And could that also be an indication for a pacemaker?
So head CT, so again, in the absence of head trauma, there's little yield for head CT, even if they can't give you a history. And because you can examine them, you can see if they failed, they have any injury or so. So outside of that, there's probably little need for head CT, especially if they have no other neurologic issues or so. The other part in terms of pacemaker, you'd have to do more monitoring. I think it's worthwhile doing more monitoring, either with a patch like the mobile cardiac telemetry, or even with an implantable loop monitor. This would be certainly an indication for that. If they are having recurrent syncope, they can't give you any other history, and you don't really know what else is going on. If they're older, the most likely arrhythmic cause of syncope for them will be bradycardia. So, but you'd want to have some kind of diagnosis before putting in the pacemaker. Yeah, ideally.
Excellent. Well, that was such a wonderful overview. Thank you very much, Dr. Kumar.
You're welcome. You're welcome. My pleasure.
Okay, well, we have reached the end of our day. Before we close, I'd like to just thank our wonderful audience for all of your wonderful, excellent questions and our incredible faculty speakers for a phenomenal day two. Just a few reminders as we wrap up. You can access all the talks from day one on demand through the website under Study Hall. Talks from today will be posted within the next 24 hours. We also encourage you to continue to access the many incredible talks in our study hall, and you will find information about obtaining CME credit on the website as well. If you're not already, please follow us on X, Threads, and Blue Sky, and we look forward to welcoming you back. We're going to start again tomorrow at 9:45 a.m. We've got a great talk to open the day, Cirrhosis for the Hospitalist. You will not want to miss it. Good evening, everyone. We'll see you tomorrow.